Okay, good afternoon. This is Eric Christensen with Healthcare Compliance Pros. I want to welcome you to our MIPS webinar and kind of the birth of MIPS. We will be answering questions as we go along. This webinar will be recorded, so there will be the opportunity to get a copy or get a link to the recording post-webinar. On the line with me today will be Chad Schiffman. He is the Director of Compliance for Healthcare Compliance Pros, and myself, Eric Christensen, Director of Client Services. And we will be answering questions as they come through our process. So if you have any questions come up during the presentation, go ahead and type them into the question box on the GoToWebinar app that exists in that app screen or that tile on the side, and we'll answer them as they come up in the course of the presentation. It's better to answer them as they come up, as they pertain to the information which we're reviewing. So let's just do a little bit of background. We had the SGR in 1997. It continued to be a fix. Every year, the SGR had to be amended, usually some kind of a budget fix that kept the SGR going. And in 2015, there was the repeal of the SGR through the Medicare Access and CHIP Reauthorization Act of 2015. That repealed and established MACRA, which is how the acronym came of MACRA, established MACRA as the repealing of the SGR, and now we needed to say, how are we going to put something else in place? And what we came up with is this new, what we're calling MIPS as far as this presentation, but it's the Quality Payment Program. And the Quality Payment Program is the CMS implementation of the requirements under MACRA to set up a new payment program and to be revenue neutral. The idea is you're not supposed to expend any more money than you did under the old programs, but you're supposed to take money away from low-performing practices, low-performing providers, and give it to higher-performing providers based on the standards that they established, and that's what we're going to be talking about under this MIPS program, is the different standards. Now, is MACRA going to be repealed? We've obviously have new leadership coming into Washington, at least from the executive branch. But, again, the legislative branch had a small amount of change up, but 91% of Congress voted for the MACRA, which was, again, partly the repeal of the SGR, the Sustainable Growth Rate. So it was supported by all the medical organizations, all the physicians, the AMA, the AOE, the MGMA. Those groups are supporting it. So I don't expect that MACRA itself will change. Now, if MIPS, which is the plan put forward by CMS, changes, that would be the exception here. Would be if the executive branch, a new Secretary of Health and Human Services, pushes an agenda down into CMS. But again, we've seen that to a great extent, the executive branch has given up power to these individual entities and the directors of these individual entities, CMS being one of them. So we had released in October 14 of this year the final rules. It did establish some change in the parameters. Part of that was greater flexibility that was part of the advocacy efforts. Again, the AMA, the MGMA, the AHA, some of these others were involved in making improvements to reduce the amount of reporting threshold, reducing the amount of quality measures, creating a transition year for 2017, which we will be talking about as we move forward, and then moving resource use or cost down to 0 as a weighting for scoring in 2017. Now, remember, this is all subject to change based on what we see from regulatory oversight as it comes into case with the new Washington leadership. So So APMs, alternative payment models. This does not necessarily include advanced payment models, because we're just going to be talking about alternative payment models under this program. CPIA, which is a new reporting category for the MIPS program, the Clinical Practice Improvement Activity. So there's not specifically anything that relates to this. We're going to talk about how quality as an outgrowth of PQRS, or resource use was part of the value-based modifier. But CPIA is a completely new category, and we're going to talk about how you can do the research on what CPIA activities apply to your practice or to your clinicians. And then the composite performance score, how do we get there? We're not going to go into a huge amount of detail on how the performance score is created, because there's far too many variables. But we're going to give you some resources of how you can get there. We're going to also talk about how healthcare compliance pros can help you getting to this performance score and tracking some of these measures as well. Okay. Further on in our acronym soup, obviously we had MACRA, the Medicare Access and CHIP Reauthorization Act, but again created the quality payment programs, ended the SGR, created a new framework combining existing programs, and meaningful EHR used for MIPS, CEHRT. We're going to be talking about how the CEHRT standards established not only for 2017, but for 2018 and beyond, and how that's going to apply to your practices. So something that's different about MIPS is, as we move forward, we're going to be talking about MIPS eligible clinicians rather than MIPS eligible professionals. So it's not going to be covered entities. We're going to be talking about clinicians, including physicians, physicians assistants, nurse practitioners, any kind of these what are commonly referred to as mid-levels are going to be part of this clinician grouping, and grouping comes under this tax identification number. Two or more clinicians can come together as a group. Now, when Healthcare Compliance Pros has worked with our audits under the meaningful use programs, that has been a tremendous burden on some of these practices, as the audits were based on NPI numbers. The actual attestations were made based on individual NPI numbers. You could take different measures and report them for different providers based on their NPI number. Created a lot of different confusion and a much larger audit overhead. In fact, a very standard question that we got was, I just received an audit for 2 of my NPIs rather than the entire organization, but I still basically have to provide all of my documentation because we still met those standards as a group. We generated a lot of group reporting. So now we've moved into this idea that groups are part of that process. And we have different questions with regards to group. What creates a group? Can clinicians participate in additional groups? And I know, Chad, that we've had some questions regarding groups come in already. Is that correct?
Yeah, we have. We've had one that was specifically asked to us. Let me bring that question up. That question states, will statistics be compiled under one tax ID number for doctors whose points are tabulated by an individual doctor? If individual doctor for independent contractors, are there statistics from all their practices combined as well? So that was one of the questions we had. Okay. And I think, as you talk about that group down there, as we move on, we should answer that question in our webinar.
All right, yes, and we will be working through that as part of this process. Before we move on, were there any questions that came in, Derek? Derek is moderating this program. Derek, were there any questions that came in that need to be addressed before we move into some of the specifics?
Not yet. I think we can move on.
Okay, so I did see some questions come in, but they seem to be in relation to how the webinar is being handled rather than specifically. Okay, so Who's in and who's out? Well, CMS figures about 45% of clinicians will be in, and this again is the MIPS and APM models, not those in the advanced APMs. So we've got the Medicare Part B, physicians, PAs, NPs, and groups that include all of those, and groups that are getting a significant reimbursement from Medicare. You know, they're having 100 encounters, they're generating $30,000 in billings per provider. Those groups are part of that clinical group that will be included in MIPS. Now, 55% of clinicians won't be, but again, we've got hospital payments, clinicians that may fall under that low volume threshold below the 30,000 billed or 100 patient encounters. Providers who are in Medicare for the first year won't necessarily need to be in MIPS. They won't necessarily have a payment adjustment. And groups with participation in the payment models. Okay, so if we're, and especially those participating in advanced APMs will not be participating in MIPS. And we're not going to talk about advanced APMs as part of this webinar, because if you're involved in those, there's going to be a tremendous oversight within the advanced APM on how the scoring works and how you're participating and how you're reporting within that payment model. Okay, again, assessed as a group. So assessed as a group, the clinicians have the option to be assessed on 4 performance categories. A group is defined as that group under that TIN for that performance period in a MIPS payment year. Individual MIPS clinicians must aggregate their performance data across that tax identification number. Now, again, you may have a separate tax identification number for other members of the group, depending on how your professional corporation has been established. You may have one TIN that's for the corporation itself, and then individual providers may maintain their own TINs. You can still aggregate that into the group by reporting under the corporation's TIN rather than those individual providers' tax identification numbers. And there's not a lot of guidance on this yet, but solo and small practices may virtually group together for their MIPS reporting. We may start seeing that with some of these MSO organizations or these IPAs that create these virtual groups. But these are, again, in future years, the program will not be part of the transition year. And again, with the change that we're seeing in Washington, may not be part of a rule that's established beyond 2017 as well. One of the biggest things that came out as a result of the advocacy efforts, you know, I did a MIPS presentation on the initial rule back in June of 2016, and there was a huge amount of overhead. And as part of those advocacy efforts, again, the reporting requirements have been reduced, but also we now have this pick your pace option. And in fact, the pick your pace option was released or casually released prior to even the final rule being released. So there was some kind of headache or some kind of stress that was relieved even before the final rule was released. So in the pick your pace option, we have the option to not report any data for 2017. Now, if you choose to do that within your group or within your providers, you will automatically be subject to the 4% penalty in 2019. So we need to look at not reporting any data. Are you willing to live with that penalty? But what they've done to alleviate that is come back with this, let's get you involved in some kind of minimal way just to avoid a penalty adjustment. So report a quality measure, an improvement activity, or meet the advancing care information base measures. Do any of that, okay? And you can not receive any adjustment, but not receive a negative adjustment, which is part of the issue for many practices. As I've spoken to many practices all across the country over the summer and into the fall, it was, you know, I just need to see if I can just maintain status quo. I'm not looking for a huge benefit first year. So can we just report one measure? Or can we report a quality measure, an improvement activity, ACI-based measures for any 90-day period or more, and possibly qualify for some kind of positive adjustment. And Healthcare Compliance Pros will be helping our clients who participate in the MIPS program for helping to determine how this adjustment would work. So those quality measures, the improvement activities, you could be possibly receive some kind of an adjustment. And if you participate full bore, if you're adopting MIPS for 2017 for 90 days or more for all data, you're participating in quality, you're participating in CPI or improvement activities, you're participating in advancing care information for all 90 days, you could receive even more of an adjustment. And we're going to talk about not just the adjustment to your fee structure, but also the fact that there is a concept called exceptional performance. So as we come through here, 2016 will be the last year of performance measuring for the meaningful use, for PQRS, for the value modifier, value-based modifier. 2017 will be the first year performance for MIPS. The last year of payment under the meaningful use programs or PQRS or value modifiers based on attestations that were made for 2016 or based on quality measures that were reported as part of 2016 will be in 2018. All of that will be sunsetted with the first payments under the MIPS program taking place in 2019. So those could either be an increase in your fees based on your MIPS reporting, or they could be part of this exceptional performance bonus. Now there's a standard for exceptional performance that you have to get to a certain point threshold, and there's a separate funding for exceptional performance. It's $500 million or $500 million that was set aside as part of the MACRA program for this exceptional performance, and that is carved out amongst those who achieve exceptional performance standards. You'll also notice that it accelerates over time this MIPS adjustment to your fee structure or the MIPS negative adjustment to your fee structure based on the performance that you do. But again, we're moving forward every year. So 2018 would result in performance for 2020, 19 reporting would result in performance increase or decrease on fee structure in 2021. So any thoughts on that, Chad? Any further explanation that maybe I didn't get to on that?
I think you've covered it. I think the biggest thing for now is everybody to focus on, this transition year idea that they put in, and I believe you're going to cover that here a little bit more.
Yeah, so we will cover the transition here, but this idea of using 2017 to evaluate your program, get everything up and running, we're also going to be talking about there's some standards that need to be met that maybe you're going to have to work with vendors to meet, and that gives you a good opportunity during the transition year as well. So I've talked about them before. We talked about this concept of MIPS. It's a new baby. Let's bring some fun into this. Quality, resource use, clinical practice improvement activities, and advancing care information. So how are we going to be breaking the pie up? How do we report, and what's the value of all of these standards? Okay, so if we choose to participate in MIPS full bore in 2017, this is how the pie gets broken up. 60% of your composite score will be generated on quality measures. Part of it, 15%, will be on improvement activities. We'll get into the specifics on these in just a moment. And 25% will be made up of ACI or advancing care information, the replacement for meaningful use. And as you can see, we move on to 2018, 2019. Cost continues to be a larger segment of how we're rewarding our clinicians, okay? And fixed by statutes for the first 2 payment years, we know that that's going to happen, but again, we have we have executive change in Washington. I don't want to say that this isn't going to be the way that it's going to be moving forward for 18, 19, 20, but I expect that there will be some tweaks to it as we move forward. How do we get to our composite score? Okay, well, we talk about things such as quality improvement activities, ACI, And can we get to 70 points as a total? If we can get to 70 points as part of our exceptional performance, there's an automatic breakup of that $500 million or $500 million that would be shared between those eligible groups that achieved that exceptional performance threshold. Regardless of how you participate under how you scored against your peers, which is how the MIPS program works, the exceptional performance bonus kicks in at 70 points. So if you get 71 points, if you get 76 points, you're still part of that exceptional performance threshold and get a share of that bonus money based on the number of clinicians that end up getting to the 70-point threshold. So that's something to think of in 2017, and we're working directly with our clients to try and establish a 70-point threshold so that they can get to that exceptional performance bonus. Okay? So let's get into quality. Spans the 6 national quality strategy domains: patient safety, person and caregiver-centered experience, communication and care coordination, effective clinical care, population health, cost reduction and efficiency. Now there is a link in here to the quality measures, actually to all of the measures, and if you receive this PowerPoint presentation, it's going to take you over to the CMS site on the quality payment program. In fact, I'm going to take us over to that screen right now just to show you how the process works. Okay, so if we come over to that, the quality payment program screen, again, another one of those acronyms the government throws at us. So we're talking about quality payment programs, or are we talking about MIPS, or are we talking about APMs? But the MIPS overview under the quality programs gives you the ability to come in, look at the measures as you come into these tabs. So for example, I want to select a quality measure for pain management. I can come in and I can search for pain, and here's a pain assessment and follow-up. I've determined that my group wants to look at that as a quality measure. I can dig in and find out what the requirements are on that, or I can add that as a measure to build an Excel spreadsheet for tracking those measures over time. So that's something that CMS has built for us on this quality measures on how we can report on that. Okay, the same thing exists on this link as we move through ACI, or Advancing Care Information. There are measures that we can be looking at and how they score. So if I want to clinical data registry reporting, I want to understand how that score works, or I want to look at electronic case reporting, I can look at that measure and see how that measure works as well. And we could move on to clinical practice or improvement activities, okay, and we can look how those measures work. We can again add them and download them as Excel spreadsheets for tracking within this quality payment program. Hey, Derek, have we had any questions come in at all regarding quality or some of the measure reporting?
Yeah, we've had actually a few questions come in. Okay. The first one was from Terry, and she was wondering, if I'm in the top quality and lowest cost group, what is the % incentive I will get, and how does the formula lay out for exceptional performance? How do I look at my 2015 QRUR to guesstimate my performance score for 2017?
Okay, so that's something that we would want to look at specifically and look at your scoring and how that represents. As far as exceptional performance, the exceptional performance score kicks in at 70 points regardless of the activities that you participated in and your scoring within those activities. So if you wanted to get more activities involved, you'll want to get to 70 points regardless of what you had a low score in cost, but you had a high score in quality, or you had a high score in advancing care information, you could still get to those 70 points. So that's where I'm saying that you're not weighed against your other peers like you under the MIPS program if you can reach that exceptional quality standard. Okay.
And we are actually having quite a few questions come in, and if we don't get to your questions, we will be sending you an email after with an answer. We had Gail ask, they picked 6. Do they have to cross domains like before?
No, they don't necessarily have to cross domains. it spans those domains, but doesn't have to, and it doesn't have to cross domains, and you don't necessarily have to have a cross-cutting measure as well. Chad, any thoughts on that?
No, I think that answered it about what she was looking for, I guess, by her question.
Right.
And Sylvia asked a question, how will quality measures be submitted? Will it be the same system we are using now for PQRS?
No, there's another, there's either a clinical data registry, your EHR may have a direct link, or your practice management system may have a direct link. In the conversations that I had at the MGMA National Conference with the EMR and practice management vendors, those direct links were, again, dollar signs in their minds of if those links will be established and what those links may cost. But those links should be established through the EMR or through your practice management process.
Could you describe a bit about how HCP works with clients to choose measures and help with QPP?
Okay, yeah, we'll get to that as we move on. We have an entire program called MIPS Plus that we work with our clients, and I'll talk about that here towards the end about how we work with them on selecting measures, how the scoring works. And how Healthcare Compliance Pros works with the clients that way. Okay.
Okay.
Is that it?
No, we have a few more.
Okay.
But we can definitely email afterwards. Let's see. Melissa did ask this question. If I have a patient-facing physician, do they need to complete 6 or 7 quality measures?
Chad?
I am taking a look right now. I believe it's 6 for a patient-facing.
Yeah. Okay, and that's the quality measures. Now we haven't gotten over to some of the other measures. And again, cost isn't part of 2017 anyway. Advancing care information will have a different set of measures, and improvement activities, there's another set of measures that way. And we will talk about those measures as well.
I think some of these questions will be answered too in the sections that are to follow. Lisa.
Yeah, as we move forward, we'll move forward through some of these questions. Okay, so we talked about how the measures can be selected. There, you can determine your standards for selecting those measures under quality. Cost, again, not measured in 2017, but will be reported on. So they're still going to be doing feedback for 2017 based on your claims data, the same way that they were doing the value-based modifier. Will be all measures will be calculated by CMS. No separate reporting will be required for that. So cost is really going to be establishing a baseline as we move into 2018. You'll want to look at the reporting. You do have a limited time to request for corrections on those. That's guidance that we give to our clients as well. But that feedback is something that you're going to want to be tracking in 2017 to establish your cost standings for 2018. Okay. CPIA, probably the most misunderstood portion of MIPS, and the activities will be weighted high to medium. As we talked about under improvement activities as we moved forward, we have care coordination, care transition. Do you have urgent care availability for your practice? Do you collect and use patient experience and satisfaction data? Those kinds of things are part of what we call the CPIA activities. They can be weighted high or medium. You need to have 4 mediums or 2 high-weighted activities. Now, the other thing that's great about the clinical practice improvement activities are that they are weighted for your entire group, even if only one provider or one clinician achieves them. So if, for example, you have a clinician who opens their practice to increasing diversity, they're a first responder, that qualifies as a clinical practice improvement activity and applies to your entire group. So you'll need to look at your group as a whole to see if you can get value for things that you're already doing. And that's probably one of my biggest takeaways from CPIA is you may be doing some of these, care transition, You may be having a prescription drug monitoring program already in place. And again, if you're doing some of these things already, you need to look at what the requirements are for meeting those standards. But again, with a few tweaks here or there, you may be meeting some of those CPIA systems already, and you'll need to be looking at those. But again, when I look at the CMS website on the measures, these are all listed out there, giving you the points or the high standards or the medium standards, and all of those points are part of that process as well. Okay.
And I believe there's a total of, what is it, 14 high and 78 or medium.
Medium.
Choose from,
yeah.
Whatever, right?
Okay.
Yeah.
So, I think one of the biggest things that we saw going into 2016 was, what was going to happen with the sunsetting of meaningful use. Meaningful use seemed to be very burdensome. As I've gone out and done presentations in person to various groups all over the country, are you making money under meaningful use? Has meaningful use changed your patient encounters? Have they decreased the quality of care that you're actually giving to patient because of, the overhead of meaningful use? And, that's where CMS has gotten feedback to reduce the burden, increase flexibility, improve patient outcomes from things other than CPIA. And this is probably the fun one that came out January 2016. We're going to end meaningful use. Meaningful use as it existed is effectively over. Now replaced with something better is a matter of how your, what your individual take is on the standard. But ACI, or Advancing Care Information, has a direct translation over to meaningful use, but some of the standards and some of the requirements have changed. Let's talk about 2017 will pretty much be, modified stage 2 for certified electronic health record technologies for 2014, stage 3 for those who meet the stage 15 or the CHRT standard for 2015, and how those programs will work. Okay, so obviously it's equivalent to the meaningful use program. 4 high priority objectives which are part of the base scoring. Okay, first of all, security of PHI. That's a very big issue. We'll talk about the failure points of PHI and security of PHI for meaningful use. Patient access, giving patients access. Now, what's interesting about this is we'll talk about this before, but patient access has changed from guaranteeing that patient access has occurred to did you give the patient opportunity to access? And I know in a lot of our subspecialty groups, patient access to patient portals, those kinds of things, have been very difficult when it's a single incident of care to create an access point. Coordination of care through patient engagement, health information exchange, not necessarily the HIE or the state-run information exchanges, but are you doing information exchange through electronic systems? Are you doing a summary of care document that's taken and exchanged electronically through some kind of encrypted standard and utilized as developing a plan of care as we move over to a new provider? So that's part of some of those high priority objectives. So in 2017, ACI and the scoring for ACI, 50% of the ACI score will be in the base score. The 4 required objectives: performing a security risk analysis, and this talks about in further education that we do with our clients, protecting patient information, e-prescribing, providing patient access to their data, and again, the health information exchange. This is 2017 and the standards that are established here. Now, as we move into 2018 and beyond, now we've added the summary of care information, requesting, accepting summary of care documentations from referrals or from transitions of cares to other providers are part of those scoring as we move into 2018. So what are some of the challenges that we're going to be looking at from the ACI program? So whether it's 4 objectives in 2017 or 5 objectives, it's still going to be easy, but it's all or nothing. You're either going to achieve your base score, which if we go back to the charting that I did earlier, we talked about the base score is one of those objectives that could result in a non-negative adjustment in 2019, meeting the base score. But it's still all or nothing. You must categorize all of those. Also understand that the majority of your ACI is still being performed through the attestation process, either through a yes/no statement or a numerator that is other than 0. So you gave patients access. How many patients accessed? Is if the number is greater than 1, you've met that standard. Okay. But the base scores and the performance scores, it's probably a mistype on here, is going to possibly necessitate third-party actions. And again, there's no thresholds that need to be met. If you meet that threshold, if even one patient interacts that way, then you've met that threshold for some of that scoring. Again, CEHRT is optional. 2015 standard is optional for 2017, but is a requirement in 2018. Look at the numbers here. In 2014, or the 2014 edition of CEHRT, 4,225 products are certified to meet that standard. But look at the standards that are adopted for 2015. Only 19 products meet the standard for 2015 CEHRT. 12 of those belong to Epic. So you know you're going to have to be working with your vendors as you move through the transition year in 2017. You're going to be wanting to ask the questions of your EHR and PM vendors. Are they going to be meeting those standards for the 2015 CEHRT standards through 2017? And look at it from a challenge aspect of, are you going to have some technology restraints? Are you going to have some monetary or fiscal restraints? Are you going to have some challenges meeting those standards within your workforce? Some trainings that will be required for your workforce to be up on new health record technology through 2017. So those are some of the challenges as we move forward through 2017 or this transition year. Okay, Derek, is this probably a good time to see if there's any additional questions that came in specifically to ACI or clinical practice improvement?
Let's see here. We haven't had one for about 10 minutes or so.
Okay.
We did have a question. If we've been meeting a CPIA for 4 years already, do they still count as practice improvement since it's not new to us?
Yeah, it doesn't necessarily have to be new to you, and that's what I'm saying with the CPIA standards. Is I would be looking at things that you're already doing. The other thing that you can do with the CPIA standards is make sure that if you're going to meet them, include them as part of the carve-out for your practice in a marketing stance or to build reputation for your practice. Well, you know, our practice is open to meet urgent care requirements, or, you know, our, 2 of our physicians were first responders, for the hurricane that happened. Those kinds of things can be used in marketing, but also meet those CPIA activities, and they don't have to be new. You may already be meeting some of those challenges for improvement activities, and talk to your physicians. Look at the list, talk to your providers and your clinicians and see if they're already meeting some of those standards.
And Catherine was wondering, how can a small dermatology practice meet the practice improvement measures?
Yeah, well, that's going to be a little bit tougher, but again, they're a very small carve-out overall of the standard as far as the scoring. If you see improvement activities stay at 15%, so if you can even meet some of the improvement activities, even 1 or 2 of them, you're still going to get some scoring on it. It's only 15% of your performance score overall to meet the improvement activities. So you're going to have to be very judicious about selecting improvement activities and looking at whether you can get better scoring in your quality and better scorement in your advancing care information to offset possible decreases in scoring and improvement activities. Any thoughts on that, Chad?
I agree. And then also, the small dermatology practices, I would recommend, it's more on the quality side, but taking a look at some of those specialty practice sets as well. We'll talk a little bit more about that.
Yeah, well, the specialty practice sets, as we get into individual groups, and that's something that was brought up in an earlier question, how can I look at this measure? How can I look at that measure? That's going to be a challenge that I can't meet in this webinar to talk about specific measures, to talk about specific reporting standards. That's part of what HCP has done with our MIPS program. So ACI is 25% of the total MIPS composite score. There are 155 available points, but if you can meet 100 of those, you can get the full 25% score in your composite score. You have to get your base score of 50 points. The performance score is worth up to 7, with 7 options is worth up to 90 points in 2017. But again, meeting the base score in 2017 results in a non-negative adjustment for the 2019 fee schedules. There are some bonus opportunities for using clinical data registries or reporting via CEHRT. Again, the CEHRT standards for 2017 and 2018, we do have that upgrade that's required if you're not already meeting it for 2015 CEHRT. There is 90-day reporting. It is not a full year reporting for 2017. One of the biggest caveats that was brought up as part of the final rule was this 90-day reporting. As I was working with groups again over the summer and into the early fall before we had the Pick Your Pace announcement, I'm going to have to hit the ground running January 1st, 2017, and I'm going to have a late announcement of the standards. So again, as part of those advocacy efforts, we moved down to a 90-day reporting. If you choose to try and meet a positive adjustment. Again, if you just meet the base scores, you can result in a non-negative adjustments. You can avoid ACI, like I just said previously, in 2017, as long as you're meeting the quality standards, as long as you get at least 3 points, that means meeting one quality standard, you can get 3 points. And the points go up from there, but as long as you get 3 points, you're going to get a non-negative adjustment. That's just doing one measure reporting, okay? And then HCP will be updating our MIPS Plus clients with additional updates and resources as we move forward, as the standard becomes adopted, as we look at whether all of these different EMR vendors are going to be able to meet the 2015 standards as we move it through and into 2018, okay? So ultimately, payment adjustments are going to sunset after 2018. Any of the payment adjustments that were part of PQRS or VBM. Best pathway to participate in the quality payment program, because we have this Pick Your Pace or transition year in 2017, this is your time. The deadline, although it isn't January 1st, 2017, is going to turn into January 1st, 2018. But now we have a transition year to make sure that you know the standards and that we can work with you to get those standards and get them dialed in, not only for your practice, but for your physicians as well. And again, having a discussion on clinical practice improvement activities. And HCP, we're going to continue to monitor the MIPS and advanced APMs as additional guidance is released, as those APM models become further dialed in, as the small group practice. So if you talk about those that dermatology group that had the question about that small single dermatologist, well, maybe as new standards come across for small practice grouping, maybe that'll be an additional resource for them, and HCP will be tracking that as well. Do you have any questions before we move on just a little bit that haven't been?
Looks like you've gone over most of this just within the presentation.
Okay.
If you only need one to meet the measure, are they evaluating your performance against peers for future determinations?
Well, they won't be judging that measure against your peers for that non-negative adjustment. You will have to add to that one measure as you move into 2018, where the composite score will then kick in and you will be forced to be judged against your peers moving into 2018. Again, 2017 is this transition year of let's get a couple of scores out there, let's understand how the reporting mechanisms work. I only have to report for 90 days to meet that measure. I can do that anytime before October 1st of 2017 to still get 90 days through the rest of 2017. So I do have time to make that transition. I do have time to make that decision. But again, that one score to get a non-negative adjustment is only for the 2017 period. You are not scored against your peers. You just have to report to get the 3 points to meet that non-negative reporting requirement.
Can the 90 days be any quarter of the year, or can they wait until the last quarter to collect data?
Well, like I said, you can look at the last quarter. That wouldn't be my recommendation because I'm worried about a failure in the system in some way towards meeting that last quarter. I'd be trying to look before that last quarter, but I did say that yes, as you move towards an October 1 deadline for last chance for implementation, yes, you can report in that last quarter if that's what you choose to do. That would not be my recommendation. I don't know of any practice consultant or practice manager who would make a recommendation to move your scoring to the last quarter. There's too many chances of a failure point, and then you have no recourse at that point. Okay. So from a compliance perspective, policies and procedures, even under your MIPS program, do you have training for your employees on what your MIPS standards are going to be? Are you relating that to your employees? Security risk analysis and corrective action plan. I didn't include it in my slides here. It is part of my longer slides. I do have a presentation on the MIPS program that's more than 100 slides long. Couldn't possibly get that done in an hour. But the security risk analysis was the failure point in more than 62% of meaningful use failures. And a properly conducted security risk analysis. Even large hospital organizations have had to return meaningful use money from security risk analysis failures, even with large IT departments, because an SRA is not specifically IT driven and must include a corrective action plan to correct deficiencies. So we need to make sure that that's being done. And possibly that it's independently evaluated, because your SRA performed internally may not be actually evaluating deficiencies in their own departments, especially from IT groups. Provide training, again, for your providers, your administrators, and your employees on your policies, on your security as part of your program, especially from the MIPS as you move through your implementation program. Estimate your MIPS score. Again, that's part of a program that Healthcare Compliance Pros is offering to our clients under the MIPS Plus program. Plan ahead. Perfect. There's a perfect example of that question that we just had come in, Derek. Be ready ahead of time. Don't be looking for that fourth quarter reporting deadline, because there is no failure point there for any kind of correction that needs to be made. So be ready for those deadlines ahead of time, okay? So Healthcare Compliance Pros, we're about managing this entire process. We even manage the MIPS process through policies and procedures, through your program under our MIPS Plus. So under MIPS Plus, we're providing additional education resources, we're doing scoring help with your groups, we're helping you to pick measures. We have a MIPS tracker that's part of this program. Exclusive content, exclusive education for MIPS Plus participants, a MIPS Insider newsletter including all of the releases and how they apply to your organization, a MIPS tracker and scoring. That's exactly those questions that we had come in. Do those what do those standards mean? How do they score out? What standards should I adopt within my practice? We all build that into our MIPS tracker here at HCP. It includes online education under the MIPS Plus program, all of the worksheets, all of the materials, and HCP's award-winning support. If you talk to anybody about healthcare compliance pros, it's the support that we offer, the feedback, and the instant availability of your compliance specialist to meet your standards under our MIPS Plus program. So that's something that we can continue to offer to our groups as we put them together. So just as a quick, as a quick question, do you think you have a good handle on the quality payment program? Do you feel like you have understanding of MIPS and how APMs work? Okay, I appreciate those giving their responses. It's about 50-50. We've got about 54% feel like they have a pretty good handle on the program. But if that's the case, I guess my next question would be, what section of the MIPS program causes you the most stress? And as those numbers come in, we see that CPIA leading the charge, and that's relatively concurrent with all of the other information that I've collected regarding this program. CPIA is the unknown, but I think what you're going to find out as you move through those activities, and as HCP helps you define what the CPIA activities are for your practice, that you may, in fact, be meeting those standards or require some minor tweaks to some of those standards to actually meet those. And when I'm looking at that exceptional performance bonus that's available, there's a very easy path for a great deal of my eligible clinicians out there to meet those exceptional bonus. So we may not be able to receive, or we may not want to participate in MIPS to get a positive adjustment of 4%. We may not be able to do and get an entire score. We may not want to be reviewed against our peers to get that positive adjustment. But to get to that 70-point exceptional performance benefit or bonus threshold is a reachable target and can impact your practice greatly with the least amount of effort on your part. So that's part of what HCP is doing through our tracking, is making sure that we meet those standards as well. Okay. Here's your chance. Wow, I even did it to myself here, guys. I gave you my direct email address. You can reach out to me directly if you've got questions on how MIPS works, if you've got questions that weren't answered directly. Healthcare Compliance Pros is here to be your advocate, to be your help in this entire issue of compliance, whether it be MIPS compliance, HIPAA compliance, fraud, waste, and abuse, or CMS's requirements on compliance. HCP takes on, we manage your compliance program, and MIPS is no different. We're going to be managing MIPS for our MIPS Plus programs just as well. So again, I appreciate your time. Do we have any other questions that have come in before I finish up here, Derek?
We are having a few questions, wondering how to actually get in with MIPS Plus. If you want to just go over that for a second.
Well, just reach out to me with the at this email address. We'll also be sending out a poll or a survey after this that you can fill out. We'll reach out to you directly on how the MIPS Plus program works for our clients here at Healthcare Compliance Pros. Okay?
And I did want to briefly say we will be sending a copy of the presentation in an email after this webinar. A few people have asked for that. So.
Okay, yeah. Again, the presentation, this presentation will be readily available. We will be doing exclusive webinar-only presentations with open forum questions or open mic questions directly for our MIPS participants as part of the MIPS Plus program. That's part of our continuing education program. But you will also have direct access to your compliance advisors with regards to MIPS and all of your MIPS questions, including scoring and tracking processes. Okay?